I'm pleased to welcome also our first distinguished lecturer, Dr. Kathy Knaffel, who is joining us from the University of North Carolina, Chapel Hill via Chicago. We're so pleased that she was able to arrange her schedule to be with us today as well. Dr. Feetham's positions in academia at Wayne State University, at the University of Illinois Chicago, in health systems at Children's National Medical Center, and at the federal government, both at the National Institute of Nursing Research and at the Health Resources and Services Administration, gave her a broad perspective on science and on science policy and the impact that those have on the lives of children and their families. She developed the Feetham Family Functioning Survey, which is used today in research of families across disciplines and has been known to have 8 translations in different languages and comes from an asset-based versus a deficit-based approach. Dr. Feetham has many honors and awards. Most notably, she was designated as a living legend of the American Academy of Nursing and was awarded an honorary degree, Doctor of Laws degree from Wayne State University. Dr. Feetham's leadership and scholarship demonstrate a sustained legacy in advancing the science of research with and for families, the integration of genetics and genomics in the practice of all health professionals, and informing policy to advance health equity for at-risk populations. Her commitment to mentoring students and professionals assures the sustained impact of these important contributions. Before I introduce Dr. Hinds, I'd also like to thank the members of the Pediatric Nursing Research Consortium of Milwaukee, Marquette University with Dean Janet Krejci, Children's Hospital of Wisconsin, Vice President and CNO Nancy Coram, and UWM Dean Kelly Lipwack for their additional supports, which allowed Dr. Hinds to spend the day as a visiting scholar, culminating in this lecture. And so now for Dr. Hinds. Dr. Hinds is the Executive Director of the Department of Nursing Science, Professional Practice, and Quality, and the William and Joanne Conway Endowed Chair in Nursing Research, and the Research Integrity Officer at the Children's National Health System in Washington, D.C. She's also a professor of pediatrics at the George Washington University School of Medicine and Health Science, also in Washington. Dr. Hinds received her undergraduate degree from the University of Vermont in Burlington, Vermont, and her MSN and PhDs from the University of Arizona, Tucson, in psychiatric nursing and clinical nursing research. For more than 3 decades, Dr. Hinds has created and led research related to pediatric cancer experience, quality of life, fatigue, and altered sleep during the treatment of pediatric cancers and end-of-life communication and decision-making. She served on the former Institute of Medicine, now the National Academy of Medicine, Committee on End-of-Life and Palliative Care for Children in America and for Dying in America, and for the National Quality Forum Panel on Palliative and End-of-Life Care in America. She's currently serving on the National Academies of Sciences, Engineering, and Medicine's Roundtable on Quality Care for People with Serious Illness, and the National Cancer Institute's Moonshot Tolerability Steering Committee. I love that name. So Dr. Hinds is an Oncology Nursing Society Distinguished Nurse Researcher and the Association of Pediatric Oncology and Hematology Distinguished Nurse Researcher. She served on the National Cancer Institute Symptom and Quality of Life Scientific Committee and the National Institute of Nursing Research Ad Hoc Evaluation Advisory Committee, End of Life and Palliative Care Science. And she's the editor-in-chief for the journal Cancer Nursing. So we are very pleased to have Dr. Hinds join us today to share her perspectives on protecting the health of families of children receiving palliative care.
Hello to each of you, and thank you so much for welcoming me here, and particularly to allow me to offer comments to you on this topic. I believe firmly that you and I have a role in protecting the health of families who we may never meet, but through our science, through what we do for other families, we are able to protect their health. And if we can protect the health of families, you and I can protect the health of a nation. And I bring you very special and friendly greetings from Children's National Health System in Washington, D.C., We are about 330 beds strong, and probably a third of those beds are critical care. And we fully anticipate that in the near future, nearly 50% of all of our inpatient beds will be for critical care. At the same time, we offer primary care in Washington, Southern Maryland, and Northern Virginia. And it is so great for those of us who do palliative and end of life care and research to have the gift of seeing well children in our midst as well. We are a magnet hospital and we are a leapfrog institution. But what gives me very special pleasure today is to join you in paying homage to Dr. Suzanne Feetham. Dr. Feetham has this amazing talent to put one idea with another idea and to put people together with ideas. I so hope that each of you have the privilege of being with her and learning from her. It has been my privilege to be her colleague and her friend. But I also want to pay homage to your collaboration. How excellent that you have colleges of nursing aligned with your practice partners, academic nurses in university settings and academic nurses in practice settings. That is the way for us to take care of the health of a nation and most certainly of families. During our time together, I am very hopeful that we will be able to analyze together a construct from our research called Being a Good Parent to My Seriously Ill Child, and to look at what we can do then through that construct to protect the health of families. Often unseen and unrecognized will be the behaviors that we will speak of today that help us to protect the health of families before, during, and after the loss of a child family member. There are many, many books available to us in this country all about raising children. Thousands of books about parenting. Many of those books have the faces of happy adults, happy children, and they are filled with worthwhile content about how you and I can actually raise these children in our society. Now, there's also on the market a smaller subset of books that are all about special age groups. How can we have a happy toddler? How can we have a happy teenager? So very practical and useful information in these books. And there's a smaller subset that also acknowledges that there are children who lead a harder life. Children who have a diagnosis of an emotional disorder or a mental disorder, or children who will grow up having an adult who is quite ill chronically. But there are only a limited number of books that talk about children who are born ill and live a life of being ill. This literature is written by healthcare professionals, but also parents. And collectively, the content of these books have led to one text that is called Parenting Matters. And this text comes to us from the National Academies of the Sciences, Engineering, and Medicine. And it collates all the information that we have across different groups of ill children and parents. And what is clearly confirmed by the evidence that is summarized in this text is that having a committed parent to a child makes a difference with that child's health in every domain of health. Parenting does indeed matter. But I can share with you, there are no books about what parenting is for a dying child. No books written by parents, no books written by us as healthcare professionals. It is almost as if we go from having a very ill child and a parenting role to bereavement and the parenting role. Something happens in between, but we're not talking about it through texts. We know in some ways it's not really a straightforward connection. We wish that it could be, but we know that there's a connection and something very important happens in between. If you look at our data with us, you will know that there is need for a bridge, parents are very clear that they know they, as the parents of a dying child, are going into a very foreign land. No pathway, wanting very much to have support to go through this, and assuming that we, as healthcare professionals, will be their bridge. We will take them across what this land is. And yet, if you and I look at our policies and procedures from our healthcare settings, we are forbidden from certain roles that might be supportive of parents bridging into this land. And much more likely is the bridge that has cracks, open gaps, and is crooked, that these parents will then follow, and that they are looking for you and I to be somewhere along that bridge to support them as they venture forward with this amazing whole now that once was their child. When I began my career as a nurse, gosh, I was excited and I was completely focused on the child. I wanted to hear the child's voice. I wanted to help that voice to be heard in every illness situation that there might be. Started out looking at hopefulness because I really had learned the difference in being a critical care nurse of those adolescents who had hope when they were admitted to our critical care units and those who did not. And I often ask them, how is it that you have been able to survive so well this amazing life difficulty? And as you know, adolescents put everything into very few words, and they would look at me and say, it was hope. I had hope. And so that started me on that career. And then learning about hope also taught me about suffering and symptoms that children had. And that took me into the world of pain, fatigue, sleeplessness for children who were very seriously ill. And in turn, that took me into end-of-life decision-making and learning from children how it was that they participated in their own end-of-life decision-making. And it was these children who said to me, I really like being in your studies, and I really think you should be studying my parents. I'm very worried about them. Please, won't you have a study for parents who have children who are not going to survive? And that took me into a very different kind of science that taught me the value of doing research that helps you and I to be part of that really rockety bridge for parents who will live a very long life, but without their child. And we do this research because we believe that this is how we can protect these families. We want to protect their health. We know from a very limited literature from 1/3 to 1/4 of all families who lose a child that they begin to experience significant marital distress that they state was not there before the child's illness and the child's death. Anecdotally, and a few descriptive studies, we know from siblings who survive the loss of a sibling that they also find life to be having special challenges. And in particular, they tell us about having a harder time making a friend and keeping a friend. But what we know from a nationwide study is that fathers who lose a child are significantly more likely to die younger than fathers who do not lose a child. They are significantly more likely to have to leave the workforce, and thus the family loses economic stability. And they are significantly more likely to die younger than fathers who have never lost a child. Mothers are significantly more likely to have a first psychiatric hospitalization than moms who have never lost a child. Now, this is not every mom, and it's not every dad who experiences these very concerning outcomes, but they are more vulnerable than parents who have never lost a child. There's a second reason that I believe you and I should be a part of a bridge for these families, and that is that you and I have access to these families. Although the rate of children dying in hospitals and other facilities has decreased over the past 10 years from the mid 75% down to about 67% of children who die in America. The great majority still die with us. The great majority of bereaved families will not have access to professional bereavement support. And yet we know that those who do have that access have better health outcomes than those who do not have access. That suggests to me that you and I, who are in hospital or other healthcare settings in contact with these families, we may be the last healthcare professionals who have contact with them. And to me, that translates into a moral commitment to create interventions for families that are low burden for them and for staff, low cost, culturally sensitive, and effective, such that when they leave our care, they are still supported by that intervention. And thus began our end-of-life research with parents whose children were not going to survive. We started working with parents of children who had cancer. And we asked them what it was that helped them to make a decision related to end-of-life care for their very ill child. And they identified 9 factors. Most of these we thought as a research team we understood. Things like avoiding more negative outcomes for my child, wanting the time left that I had with my child to be good, believing that everything that could be done had been done, helped by our faith. But there was this one factor that kept coming forward, deciding as a good parent would. And we really did not know the meaning of that construct and kept talking with each other about what did it mean. We had interview data that we thought would help us to understand this, but I'd like to share with you 2 quotes from 2 moms similarly aged, of 2 adolescent daughters similarly aged, and treated the daughters on both the same protocol for acute lymphoblastic leukemia. And these 2 moms were in our study, and they made a decision about resuscitation. And they both made their decision based on an internal definition of being a good parent to their daughter at that moment. I'd like to read the quote from one parent who decided in favor of resuscitation and one parent who decided against resuscitation. So the first quote from a mom who decided in favor of resuscitation, she made the decision in order to help her child live longer and healthier, no matter the condition. And her child was actively dying from advanced leukemia that we could not control. And now from the other mom who decided against resuscitation, to let my daughter leave this world with the dignity that she entered it with, and not with someone beating on her chest. I want her to leave this world as peacefully as she can. So looking at those data, recognizing that they made opposing decisions, but for the very same reason, being a good parent to my very ill child, helped us to know that this was far more complicated than some of the other factors that had been identified. So we continued pursuing that end-of-life decision-making. And across 4 studies in particular, this same factor came forward, now with parents not just involving children who would die of an advanced cancer, but children who would die of other reasons. And at least 84% of all of our parents in each of those studies said the number one reason was trying to be a good parent to their very ill child at this time. That justified for us learning more. So we went back to the NIH to seek more funding to pursue learning about being a good parent to a very ill child. And based on all of our own data and the data from really powerful studies done by other people, we went into the study with this model, and I'll just briefly tell you about it. what you will notice is that parents began really seeking cure and being determined to find that cure. And they describe having a life of going after that cure, and it was endless, constant effort, steep incline. You couldn't go anywhere without thinking about it, not even your most favorite place or your most favorite activity. You could never get away from needing to find cure for your child. Very quietly, along the way, you began to notice that not everybody was cured. And you began to entertain the thought that just maybe your child might not be cured too. But that thought was so awful, you really couldn't entertain it for more than 60 seconds. Along the way, though, you could see that things were getting serious. Certainly, the comments that were coming from the team members were getting much more serious. You were hearing them, but you would say to the team, yeah, that's those other children. That's not our situation. We're different. And along the way, you were contacting other treatment centers, not because you were doubting your team, but because you had to be sure you were doing everything that needed to be done. And if you were not making those contacts, someone in your family or a best friend was making those contacts. And very closely, you were watching your child's body because you needed clues. You really needed to know if your child was changing. You didn't want to be taken by surprise. It's very tough for those parents whose child was on a respirator, ventilator, in an intensive care unit because everything was kept so modulated. The clues were hard to detect. And then, of course, this factor of being a good parent, which parents kept talking about. And then, when they went into end-of-life care, it seemed like a precipitous drop from this incline, so suddenly, abruptly happening. The benefit, of course, being that you could now focus on goodbye and focus on getting your family ready for this amazing loss. And what we learned is that even first-time parents whose infant was born with a life-ending condition already had within them an internal definition of being a good parent to this very ill infant. So we then pursued with R01 funding how we could define being a good parent to a very ill child. And with additional NIH funding, we began asking very directly our parents of an ill child, please would you describe for me your definition of being a good parent to your child now, at this point in your child's life. And across the first 62 parents of children who were diagnosed with incurable cancer, we learned that there were these 7 critical aspects of the definition. Now, not every parent had to have all aspects of the definition. We're trying to learn now, does the definition change over time? And can you achieve your definition if you only achieve one of these critical elements of the definition? But very clearly, all of these were identified across interviews. That took us into the next study, which helped us to look at can we clinically extract this definition from parents whose child has made an end-of-life decision, and the parents have been a part of that decision-making. Can we learn their definition of being a good parent before the child dies and share that definition with clinicians? And if we share it with clinicians, will the clinicians use that definition in their interactions with the parent? So we had this process of confirming eligibility, and we had 3 levels of eligibility being confirmed: the attending, the primary nurse, and the psychosocial expert. And once confirmed, then approaching the family and inviting the family to be in the study. And then we immediately moved forward with the family permission, sharing their definition and their ideas of what clinicians could do to help them achieve the definition with all members of the clinician team that we could reach. And in 2 to 3 weeks, we followed up with family and with staff to find out how had it been to be in the study. And with clinicians, we asked them, did the information make any difference in your practice? And oh my gosh, wasn't that a mistake? That's like asking a clinician, Couldn't you be better than you really are? We've learned not to ask that question. You know, those of us taking care of a child at end of life are already so terribly worried about doing a good job by that child. So to be asked a question that in any way implies there could be a better job done is really not thoughtful at all. I'll not be asking that one again. We had hoped that at least 60% of families who were eligible would agree to be in this study, and we were thrilled because 80% of the families said, we'd like to be in your study. And those parents who declined did so with perfectly strong, acceptable reasoning. My child's dying. I'd like to get her home so she can die at home. This would be too hard for me to talk about. I don't think I should do it. How good for me to learn that I wasn't going to be harming families. That is my number one fear as a palliative and end-of-life researcher, that I might hurt rather than help. And families at that knew what was right for them and what was wrong for them. And we followed up for those families who were in the study. First, it was hard to reach all of the families. It's amazing how many of them relocated within weeks, discontinued telephone lines within weeks. But for those that we were able to reach, the great majority said, so glad I was in your study. I never thought of myself as a good parent, and when you asked me the question, I could answer the question. That means then that I was able to do what was important for my child at that time. Well, since our first few studies, we've gone on to do a number of validation studies. And I'd like to take a moment to introduce you to two fantastic colleagues, Dr. Tessie October, a physician who's an intensive care physician in our hospital, and Dr. Chris Feudner, close colleague who works at CHOP and the University of Pennsylvania, both of whom have been very interested in this construct of being a good parent to my very ill child. I'd like to tell you why Tessie October's work goes way beyond the work that I first did, and that she did it better. She enrolled more couples. We really wanted to know, do parents have different definitions of being a good parent within the same family? And we really wanted to know, do parents of color define it differently than my predominantly Caucasian sample back in our original study? And Dr. October was able to confirm in a sample size of 40 plus parents that in fact, African American families define being a good parent to my very ill child precisely as Caucasian parents define being a good parent to my very ill child. And we were able to learn from her work that when there's a couple, the moms by far rate the most important aspect of being a good parent, making sure my child feels loved, and particularly by me. For a father, it is being well enough informed to make good medical care decisions. But if it's a single parent, and all of our single parents were moms in her study, the number one most important aspect of being a good parent is being well enough informed to make good medical care decisions. So it looks as if when you are a couple, you can afford to have differences in the rating of your characteristics. But when you are alone, it is critically important that you be able to make good medical care decisions. And then came Dr. Chris Feudner's work through a palliative care service at his hospital. We enrolled 200 families in that study, not all of whom had a life-ending illness. So this was our chance to look at differences for those children who might survive versus those parents who would not survive. And the number one most rated important aspect of being a good parent, making sure my child feels loved. So again, a very important element. But it's important for me to tell you that his sample was predominantly white, middle-class moms. So once again, a pattern of what might be rated as most important by background. So here now, I want to share with you that we have the 9 original aspects of being a good parent to my very ill child, and Dr. Feudner offered 3 more from his own clinical practice. And the 3 that he offered have the double asterisk by them, and they're in red. And I'm going to point out the differences in ratings by the 9 that were from parents themselves and the 3 that come from an expert clinician. So here are the ratings and rankings from Dr. October's study. And if you would notice the top 4 and the bottom 3. The bottom 3 come from Dr. Feudner's additions. The top 4 very much include making sure my child feels loved. Now let's look at Dr. Feudner's ratings. These are his top and bottom, and 3 of his top 4 are the very same as from Dr. October's ratings. Making sure my child feels loved, focusing on my child's health, making informed medical care decisions. And notice the bottom, keeping a positive outlook, as long as life is possible, keeping a realistic outlook. Now in both studies, my child's spiritual well-being did rank low, but in talking to the parents, it wasn't because it was unimportant. It was because they felt it had been so addressed already, they didn't have to worry about it. So nice feedback for us about this methodology. And what we've been asking ourselves in that study with Chris and in our ongoing study is, does the definition itself qualitatively change over time? Do the importance ratings of the elements of the definition change over time? And from the study led by Dr. Feudner, looks like we have at least 2 profiles. One, making sure my child feels loved, and the other, making well-informed decisions. So Dr. Feudner has followed the families over 2 years, and that again tells you that not every family in his study had a child that was dying, because these families have a child still living. So a little bit of a different background with this study sample than with our previous study samples. So 124 families were available at baseline, and then again 1 year later, and then again 2 years later. And what you'll notice is that the lighter color is the profile for making sure my child feels loved. The darker part is the profile for making good medical decisions. And what you'll notice at baseline is that most of the parents fall into equally the 2 profiles, just about half and half. 1 year later, there's been a shift, and more parents have moved into the profile of making sure my child feels loved, up to 71%. Now go forward 1 more year, another shift, and once again into making sure my child feels loved, now 79%. Now, you and I could theorize about why would a parent shift in that way. Perhaps they have the medical information they need. They're confident in the decisions that they're making. But it becomes increasingly important for them that the child recognize that the child is really loved. That means then we go into clinician behaviors. What is it that you and I can do to help parents achieve their internal definition of being a good parent, no matter what that definition might be, no matter if it changes over time? And parents are very clear that you and I are the bridge here, that we do have a role. This is also where we have more variability. So what is right for one parent may not be right for another. So in addition to asking the question, please would you share with me your definition of being a good parent now, at this point in your child's life, we need to ask the question, what may we do to help you achieve that definition at this point in time? So I'd like to share with you some of the most common of the strategies that families have recommended we use in order to help them achieve their definition of being a good parent. By far, they needed to know that we've done everything and that we've done it to our best and that to our knowledge there is nothing else. They ask us to remember them and their child and to convince them that they are memorable, that when they leave, we are not going to forget them. They ask that we continue to engage with them and include them, and that we continue to be honest with them and give information. And interestingly, they ask that we be more comfortable in asking them about their faith. They're very worried that we seem awkward about asking them about faith. And then to point out to them examples of when they've really been a very good parent to this seriously ill child. So that, of course, has led us to our current study, and I'm so privileged in this room with you and also with one consultant and one co-investigator for this study, Dr. Feetham and Dr. Knaffel. How fortunate I am. You'll recognize the original model, I'm sure, embedded in this depiction, but you'll notice that at the far end of the model, we are now focusing on parent health. We truly believe that if we can do anything to support that health, we support the family well-being and beyond. So in this study, we have a time 1 and a time 2. We're interviewing the parents at a time when a decision has been made. And it could be considered a serious decision, not necessarily life-ending. And we have 2 populations. Parents who are in the pediatric intensive care unit with their ill child, and parents of children with incurable cancer. We made that decision to have those 2 groups at the time because we honestly thought they would be such contrasts with each other. Those with incurable cancer would be families who have had long-term relationship with healthcare providers. Those in the PICU would be having a sporadic, short-term interaction with those providers. And were we wrong? There's a certain percentage now of families in our pediatric intensive care unit who are admitted often. They have children with amazingly complex chronic conditions who have acute episodes. They know the staff well. So that is not the contrast that we had originally thought. We had anticipated more trauma than we are actually seeing in our critical care. So our findings are going to be especially interesting to us as they take a life of their own. So we follow up with families 4 to 6 months after they are originally in the study and after the child has died, or after they were originally in the study because the child has not died. And so I'm going to share with you very preliminary findings from our time 1. And we're using both qualitative and quantitative findings. And I'm going to share with you the time 1 developing theoretical model. You'll notice that in the middle of the model is that core construct again of being a good parent to my very ill child. But just above it, you'll see a box, knowing my child. And what we've learned is that this is the source of legitimacy for the parent to believe that they are a good parent. When they are asked to participate in decision-making, no matter the level of decision-making, whether it's small, practical, day-to-day, or large life decision-making, they interpret that as us going to them for the source of being an expert on this child. If we do not go to them, this is also the source of what makes families angry. And particularly this is true of our families who have the complex chronically ill child, who, as they say, are the ones taking care of them 24/7 at home by themselves and know this child very well. Thank you so much. What you will notice on this side facing me of the model are several influencing factors that can directly impinge upon whether or not the parent believes they are a good parent. But you'll notice that they are in dotted lines, and that's because what I'm about to describe for you is actually very vulnerable. They can achieve this belief, and then they can lose it because of certain behaviors of others. So being on the same page as experts is incredibly important to these parents. And they'll say to me, must be, if the experts and I are on the same page, then I am making the right decision because an expert would not mislead me. So it's very important to be on the same page as the clinical care team. But you'll notice just underneath that, staff respecting my knowing of my child. is linked to that relationship with staff, and it's actually very vulnerable for when staff go ahead and change care without including the family members, or staff make a decision about care and share it, announce it, but did not involve the family in that decision-making. That is interpreted as a lack of respect for parent and family. Being doubted by others is a very difficult experience for these parents. It's very hard to get to the point of helping with a medical care decision, whether it's life-ending or life-prolonging. So to have trusted others say, "Are you sure about that decision?" is very difficult. Most frequently, it's grandparents who will say, "Are you sure you've done everything?" Fathers describe that sends them back through that same difficult decision-making path because they have to rethink what they've gotten to. Mothers describe the pain of being doubted as a good parent. Quotes from parents include, "My parents are second guessers. They didn't do this to bring me to my knees, but that's where their questioning brought me." This is also the point where we will get phone calls asking us to not allow a certain nurse or a certain doctor back into this inpatient room because they've questioned the decision-making that was done by the parent with the team. And the parent will say, "I either have to believe that I'm wrong, or I have to believe that this clinician does not really know me, and therefore I was misled in my feelings towards that clinician. I can't afford at this time to believe that I'm not a good parent, so I don't want to work with that person anymore." It's a very painful juncture for a parent to reach this point and have to lose the contact with a clinician who's been especially invaluable to them during the illness. What you'll notice down here is the parent knows they have to protect their confidence in what they're doing. This means that they will often not tolerate long conversations, just reaffirmation that they are doing the right thing. And down here, doing everything to help, never resting. Many times we'll say, "Wouldn't you like to take a break?" No, they really don't want to leave the room. And no, they really don't want us stepping in on their behalf. We're not a proxy for being a good parent to a very ill child. But they're also monitoring from this position, and they're often questioning us. "Why did you do that? That's not how you've done it before. That's not how the person before did it." It is not because they are doubting you. It's that they've got to be sure that everything has been done to the best that it can be done. As you go to the far right, you'll notice, again, that emphasis on being angry when you feel disrespected. And again, the red indicates this comes from our parents in the PICU of a child who's had a complex chronic condition almost from birth. What you'll notice in blue, just underneath that, is a very different code, and it comes from our parents of children with cancer that can't be cured. And they feel so delighted when we personalize our care. It's almost as if they don't expect it. When we talk about something that is so unique to their child that we really enjoy. And for them, that's a particularly wonderful treat of being cared for. Regrettably, and coming down a little bit lower, you'll notice another code that is true for parents of complex, chronically ill children. And they feel that in addition to doing everything they must do to be a good parent, they also have to teach us to value their child, who they know is different. This child who doesn't look like a normal child, this child who oftentimes cannot communicate in a way that we are used to, from all of those healthy children, the textbooks that we talked about, they feel it is their duty to help us value this child who is so different. So in addition to trying to help their child, they're trying to help us. And these parents talk very much about they want to see reality of their child's situation, but it is their privilege to continue to hope for a miracle. They do want to hear the facts, even when they tell us that we are wrong. They are listening, they are absorbing that into their perspective and their readiness. And what you will see is the context is they're trying very hard not to lose sight of the bigger picture of where their child is, while trying at the same time to understand the information that is coming at them, to make sense of it, to understand it. And at the moment, we believe that this is leading up to the naming of doing my best for my child's possible best. So there are a few takeaway points at this time. And one is that parents of seriously ill children do indeed have an internal definition of being a good parent to this child. And they feel a tremendous amount of pressure to achieve that definition. It takes precedent over other priorities, including other children. There is almost a desperation to achieve this. And I'm going to suggest to you that should we study it together, we as nurses and our colleagues as physicians have that same desperation to do well by this child before the child dies. And there's a second takeaway point, and that is that I believe you and I do have unique roles in helping parents to bridge into this new terrain. We haven't mapped that out completely, and we do have institutional policies and procedure that might limit us into what we can do. But we have data now that suggest we have a role. Parents will say that we are the only ones who were with them during the entire experience, and we are the only ones who saw them at their worst and could still point out to them when they did something that a good parent would do for a very ill child. And there's a third takeaway point, and that is we have every reason to believe now that parents who are supported in achieving their definition of being a good parent to a very ill child may have a greater likelihood of better health outcomes as a bereaved parent. And if they are able to do that, then we have supported family well-being. And we actually believe at Children's National that we can do something during an acute illness, a serious illness, that will protect the family for the rest of the family's lifetime. May I thank every one of you for being here today and your kind attention. And may I answer any questions, or attempt to, that you might have about this work. Thank you very much for that. And again, most especially, thank you for honoring Dr. Suzanne Feetham today.
Question?
Yes, please.
So if there were, let's say, a family that came in and the child died in like 3 days or something, so there's no studies for those families, or would there be?
I really like your point. So no good parent study about the child who comes in with trauma. And this is something we really feel beholden to do. In our intensive care unit, and we have 3, there are children who are brought in with brain death. And there is a very strict health policy that we follow for our hospital in those situations. And quite frankly, we have struggled as a research team about whether or not to approach these families. So initially, we started out saying we would approach. Hospital was supportive, IRB was supportive, and I floundered. I went to meet the family for the first time, and there was a grandmother sobbing at the bedside. I'm a grandmother, and I absolutely could not approach her about the study. And that happened 2 more times after that, and we then caucused again as a study team to say, maybe this is not what we can do, but we believe it should be done. Now, the timing of that is the great question. Should we be doing it while the child still breathes, or should we wait until sometime after the child has died? We actually think this is a priority, and I hope you will pursue it. Thank you for that question. Yes, please. Hey, Nora.
Thanks so much for that talk. Wonderful. I think all of us can see some of the similarities for other populations, of course, the populations we study. So I study families of children with autism. I'm very interested in their health. And I have a child with autism too. I've had physicians say to me, "You know, you're a good parent, right?" So this is very timely, especially because I think healthcare providers do that. Do you think that's a good thing for them to do? It affirms it, or is it patronizing, or does it need to be studied? Just what are your thoughts on labeling behaviors that you see?
I want to really commend you for picking up on that labeling. It does sound pejorative. You are a good parent. And the first time we went to an IRB to further study this, the IRB refused to approve the protocol because they thought that label was pejorative. And actually, it comes from parents. So I went back to the parents and said, "What do you think? We should change this." They said, "No, that's what it is. I need to know that I'm a good parent. And it makes me feel better when someone that I trust says it to me." So I don't think it's every condition, but I do think it needs to be said. I've also been asked, can you say it to a parent whose child's admitted because of non-accidental trauma? There are things that I believe we witness at the point of care that represent being a good parent. And I do think we can point those out and speak to them. A certain touch, a certain story told, a certain look. I've certainly seen looks between a parent and a child that represented to me what we always call the little miracles, and represent that relationship between a parent and a child, and it's worthy of commenting on. Yeah. I really appreciate the question. Thank you. Oh, good. Thank you.
So recently I heard about a concept that I guess I never even thought of, like in post-traumatic recovery, and that it was a family, the child died like within 3 days, like brain tumor, and then died or something like that. And it, anyway, so I just wondered, do you think that would be part of your like going out like further past the study to keep in touch with the parents maybe?
First of all, thank you for teaching me about that. I've not heard that term, and I want to look into that. Thank you. That could be a conceptualization that would be motivating and defensible. I think we could link important health outcomes to that. The term itself suggests that they exist. I think I better learn more about that term. I'm really grateful that you put me onto that. I didn't know. So thank you very much. We should stay in touch. Very nice. Hey, Amy.
Thank you so much for an amazing talk.
Pleasure.
In my work, I'm looking at moving more of these discussions to earlier on in the patient's trajectory.
Yes.
And so my question to you would be, what are your thoughts of how you could potentially integrate this question of how do what makes you a good parent even earlier on, so that we as clinicians can be better supporting parents throughout the trajectory of their child's serious illness. So that's part of it, and your comment on that. And then the second part would be, I know the clinicians didn't like the question you asked them, but did you get some good data from them about, did they respond to that the definitions and what the families were providing them or not?
Two great questions, and thank you, Dr. Newman. Right, so maybe the last one, well, yeah. So I actually do believe that once your child is ill, you are aware of your definition, whether it's labeled or not. We have asked parents of children who are well their definition of being a good parent to this child now, and universally, they have said, a great question, but it's a big question. I've got to think about that, and I'll get back to you. So it's in the background. Versus asking that of a parent whose child is quite ill, they immediately have an answer. And I would often say when I was getting consent, you could think about it overnight, and I'll come back to you tomorrow to see if you'd like to do the study. No, I'd like to do it now. I know what I'm going to tell you. So it's in the foreground. And that means it's available to us to learn to understand. It's very hard to go after a background concept. So I do believe that it's relevant to ask this at any point where a parent is living the experience of a seriously ill child, whether it's life-threatening, life-ending, or something that the child can recover from. But I think it's important to have milestones of when you're going to ask it and to know who on the team is going to ask it. So it's not all of us saying, and what's your definition of being a good parent to your child now? And to make that definition readily available. What we think is true clinically, but we don't know from our evidence, does that definition change at each one of those critical changes in condition? So if the child's condition changes somehow, whether it worsens or gets better, does the definition change? And does the clinician strategy need to change with it? We won't know if we don't ask. So if we set the stage for parents and say, here at Facility X, we really believe in knowing what's important to our parents. And the way that we do that is to invite our parents early on to tell us what their definition is of being a good parent. And then we ask, what can we do as clinicians to help support achieving that definition? So you will hear me ask you this definition at different times over the course of treatment. We'll prep you each time I'm going to ask, and I'll remind you of why I'm asking it, and then I'm just going to listen to you. And then with your permission, I'll share that with everybody else on the clinical care team. So yes, I think it can be shared and done at different points. What do you think? And I asked this of Dr. Newman because this is her area of expertise too. Mm-hmm. Mm-hmm.
Parents need that experience over time to be able to answer the question, but it would change, right? I mean, but I'm thinking in a more, I was going to say in a more meaningful way, but it's meaningful even in the beginning. But the fact that, as you described in the beginning, parents have to think about it, but then once you've come through this journey, you're able to say, oh no, I know what it is, to be able to better describe it. But I certainly think there's opportunity, because I don't think that we often ask those questions to really know and understand our patients and families, so that we're really meeting their needs and empowering them to be the best parent they can be.
Thank you for that. I agree with you, Dr. Newman. And I think your second question had to do with, did clinicians remember the information that was given to them about the parent definition, and did they use it? Yes and yes. And we're able to give examples of it as well. But it was only after I apologized for the offense of asking a question about, did it change your practice? And then reworded it literally in the midst of an interview. So yes, they are able to identify using it. And many of them recalled verbatim what the definition was of being a good parent for one of their families. One physician has called me over the years doing this work to say, do you know that you changed me? You changed my practice. I thought if I just looked at Caring Bridge for my families, I would know what they were really thinking. I don't. I have to ask the good parent question. So I think it is a matter of becoming comfortable with the question. I think your nice comments allude to that as well. Yeah. Thank you, Amy. Yes, please.
I think the context is also very important, because this seems relevant to me to school nurses, where you have parents with chronically ill children in schools. And that might be quite affirming to those parents who are trying to deal with that context.
That's a really excellent point, and you're the first person who's ever said that. That's really well. Thank you so much. Oh, thank you. It's a great idea.
I think we all, thank you so much all for coming, and I think you will appreciate, I certainly did appreciate the presentation. So join me in thanking Dr. Hinds for this great presentation.
Thank you very much. Thank you all.